Welcome today to another edition of Fireside Chat, and I am absolutely delighted to be joined today by Ramanan Laxminarayan, who is the organizer of the set of papers that just came out in the Lancet about the impact of antimicrobial resistance globally and what we need to be doing to address that problem. So, Ramanan, thank you for being here.
Thanks for having me.
Actually, I think I've known you long enough that I don't even remember when I first met you, but I do know that the first time I read your name was when I saw your paper in 2007, the one called Extending the Cure. And I know that you were active in the space before that. Just sort of, why don't you tell everybody briefly, what is your deep background and how in the world did you get into working on AMR?
John, I actually remember when I first met you. It was at the Swedish Embassy when you had accompanied your CEO. I obviously knew who you were before then, but we met at that time. And it was just a two-person event, just your CEO at AstraZeneca and myself. And we were talking about incentives for new drug development at that very beautiful building. This must have been, I don't know, 20 years ago, something like that. Yeah, but I got working on this after first training as an engineer and then as an economist and an epidemiologist. Primarily, I'm motivated by problems as opposed to disciplines. And the issue of antibiotic resistance has fascinated me for a long time as an issue of incentives on the supply side, of behavior and externalities, which means people not taking into account what they are doing on others, on the demand side, on people using antibiotics, the whole epidemiology of resistance. It's a fascinating issue. And as it happens, also a fairly important one, as we now realize, in terms of putting modern medicine at risk.
I actually looked back at that 2007 paper, and it's striking how similar many of the themes are. I mean, no surprise. It's just we've refined them since then, but it is interesting to see how you were writing then about exactly these said things that are going on. So I'd like to take a few minutes to have you give us a bit of a tour of the papers that just came out. It's a substantial collection of papers. There's an executive summary, 4 papers to read, and a commentary. And I think that if you would you just sort of go stepwise through the key messages from the papers and show us where to look as we read them?
So the 4 papers, as you said, talk about the epidemiology, burden, trends in resistance, surveillance. That's the first paper. The second paper does something that we have not had at a global scale, a sense of the burden of AMR that is avertible through prevention intervention specifically. The third paper really deals with the supply side, but tries to take a careful look at what is really how perhaps affordability of new antibiotics is a constraint that has been missing in how we're developing new antibiotics. And if we really want to serve the low and middle income country world, we're going to have to think about access not after we develop an antibiotic, but really, from day one. And that does make some difference to our choices, but also make some difference to how we can incentivize and bring more public money to the table. The last paper is meant to inform the UN General Assembly meeting in September, and really sets out the 4 things that we've known we need for getting progress on any issue, but particularly this one: political will, targets, funding, and then accountability and governance mechanisms.
Well, so let's start by talking about paper number 1 and the theme of the scope of the problem. And I was interested in the way that, in particular, you discussed the magnitude of the problem for bacteria relative to some other things we often talk about a lot: HIV, malaria, and AIDS.
Very often we hear this thing which says, the citing of the University of Washington paper, basically that 1.27 million people die because of AMR, and that's the problem we're focused on. And I think that is only a small part of the problem. The bigger problem we're dealing with is 7.7 million people who are dying of just 33 bacterial infections, non-TB bacterial infections. And 7.7 million bacterial infections is not just more than HIV, TB, and malaria put together. It might be 80% more than those three put together. It's a massive number. So what we have is a situation where we're under-recognizing the main problem, which is we have these 7.7 million deaths, which are either preventable or treatable with existing antibiotics, or will need new antibiotics to treat. So if we break it out in that way in our minds, then it gives us some sense for how we should be distributing our money across these three priorities. The first is prevention. And here, getting a little bit to paper two, we estimate about 750,000 deaths, which can be prevented of just AMR. The number is probably greater if you think of all bacterial infections, but we have that many infections that are preventable, which are and what we can really do there is focus on interventions that we already know a lot about: water, sanitation, and hygiene, infection prevention and control, and immunization, childhood immunization. Of these three sets of interventions, we already have funded programs for childhood immunization. We have some programs for water and sanitation. We're missing a big opportunity in infection prevention and control, especially because people are more likely to get hospitalized these days, receive institutional care, and pick up bugs when they're in the hospital. Mm-hmm. And there's a huge opportunity there with infection prevention. Then we come to, okay, we've done as much as we can on the prevention side. What can you do with existing antibiotics? And here, again, the opportunity is enormous. We have, we have not estimated that number, but there is really a delta in some sense between something like 7 million deaths, which is the top line after you've prevented about 750,000, and then 1.27. So there's a very large number that are treatable, and some work still remains to figure out exactly how many of infections are treatable if we would expand access to existing antibiotics. And just a point to make there, which is that people often think, well, antibiotics are being overused in all the LMICs, but not so much in high-income countries. It's actually far from the truth. High-income countries, on average, use twice the antibiotics per capita, per person per year, that low and middle-income countries do. So in many low-income countries, they're probably using too few antibiotics. Mm-hmm. Middle-income countries, some populations using too much, some too little, and high-income countries, largely too much. Although obviously there are pockets where there is also lack of access, but all by way of saying that focusing on access to existing antibiotics may be our biggest bang for the buck at this time in terms of addressing the burden of bacterial infections. Then we come to the third part, which is really the paper 3, which is on what do we need new antibiotics for? Now, we have to remember two things. One, there are already infections that are not treatable in many parts of the world. And they're not just in high-income countries. Many of them are in LMICs as well. And the second is, even if they are treatable today, in a few years from now, they're likely to get untreatable. So it's just a matter of time. If we wait long enough, we're going to need those antibiotics. So how do we develop them? We've had a fair amount of money go into new antibiotic development, but not enough that is commensurate with the scale of the problem. We have a very nice figure in the papers which shows that the amount of money going into AMR is a small fraction of the money that goes into HIV, AIDS, and TB. Not to say that those amounts should come down, but really to say that AMR should go up. And I think that the current drug model, as you have been saying for a long time, and we've written about for a long time, perhaps even together, is simply that we are going to need incentive programs because the market is not sufficient to be able to have a purely private system of drug development. And here, what we're suggesting is two pathways for us to explore. One pathway is really to look at public-private partnerships, which implies getting public funds, access to public programs like clinical trial networks, access to probably patient populations in countries where the public sector is willing to help pay for the trials, and also pull incentives to be able to get the incentives needed for drugs to come to market. The second is a lot of the pull incentives we've been talking about are in high-income countries. They're important for those countries. Pasteur is very important for the United States, but its applicability in making drugs affordable in outside in the rest of the world is fairly limited. It's not designed to do that, and that's therefore those drugs will not reach other countries. And here, what we urge is for the world to think about a second source of pull mechanism, which is really access programs to new antibiotics that are potentially funded perhaps through the Global Fund. And what they would enable is both the access in controlled manners, with good stewardship that goes out into LMICs of new antibiotics. And along the way, that also generates a revenue stream which allows drugs to come to market and serves as a pull mechanism there. It's something which we should have really worked on a long time ago, but it's good to get started now. And an access program of the Global Fund that pays for both existing and new antibiotics is long overdue. So that, in a summary, is really what we are discussing with respect to the burden of AMR and how we can address it.
Fabulous. And let me pick up a couple of the very specific points. In paper 2, where you're talking about the ways that we could intervene now with available tools, WASH, IPC, and vaccines, fascinating figure 5, that lays out the pathogen-specific burden that is not preventable by those implementations. And I think you mentioned at the start, this was something we didn't have before. And I was just fascinated by looking up and down at those bars. So, I see, for example, that with the typhoidal salmonella, looks like maybe you can eliminate about half of the impact of it with with WASH and vaccination, but you're not going to make it all go away. I think that's a fascinating result. There's also a commentary in the paper itself about how even doing good WASH techniques didn't always seem, every time you tested it in the next country, it wasn't consistently effective in every country, and it's suggesting you maybe need to be doing other things in that country. But it seemed to me that this was a novel bit of insight and data, and it looks as if in total you're suggesting that about a fifth of the burden of AMR can be made to go away, but no more than that on a global basis. Is that about right?
Well, at least up to remember, we're talking about increases of a certain amount of coverage. We might be able to go beyond that, but we might need, further increases coverage beyond that. However, let's get to WASH as an example. Now, WASH, the trials show that if there are, 5 or 6 interventions, you can't just do 1 or 2. You actually have to do all of them or most of them. And that's not so surprising. If you look at a high-income country, you have the reduction in infection, not because that country did 1 or 2. Take the US, for instance. The tap water is actually drinkable. Big difference from many parts of the world. You're not going to get an infection from there. You have, the sanitation is such that you don't really have to worry about the waste, sewage leaving your building or your street. There are many things that we take for granted, but even in the West, infection levels are low because all those interventions happen. You couldn't just do 3 in the US and say, I want my infection levels to go down. So if we take the high-income countries as the example of where we need to get to, there is a long way to go, but it will happen both as a result of deliberate planning, but also because as people get wealthier, they automatically are able to afford these. Today, access to piped water in India is almost 90%. It wasn't that even about 15, 20 years ago. It was far less than that. And you see that in every country by country. It's not just government programs. Those play some role. But private demand, people want these things regardless of bacterial infection. They're convenient. People don't like getting sick, all of that. Yeah. So I think that's true for WASH. Vaccination, I think there's still a long way to go for simple things like pneumococcal vaccination, where we're still hovering 60 to 65% in terms of global vaccination rates. And there are lots of opportunities in the vaccination space. MDR typhoid, again, something where the vaccination is only taken off in a few countries and far more countries need to get that. And then the last one, as we spoke about, which is IPC, where the lift is pretty significant, but also the opportunities are significant because we're starting from such a low base of IPC practices by and large that we can have the gains there that we can't think of in, say, a high upper middle income country. So all by way of saying, you're right, you can't prevent every infection away because there's still a background level of disease, but we can certainly reduce things by a significant amount.
Yeah, it's fascinating to realize that. I mean, the other thing you commented on was about the ratio of R&D dollars to target area. And in the recent paper from IHME, Christopher Murray's group, made a comment about looking at global burden of disease and about relative imbalances of spend, having lots of spend in areas that don't have a lot of global burden and relatively little spend in other areas. So I thought that was an instructive figure, and it also highlighted the need for more work, particularly on vaccines and diagnostics. I think it suggested that there was some reasonable amount of work on the therapeutics, but vaccines and diagnostics were still lagging.
I agree. I think vaccines are particularly lagging. The diagnostics are also lagging for two reasons. One is the business model for diagnostics is even worse than for drugs and vaccines, where it's already pretty bad. And you're aware of this. No one's willing to pay for diagnostics. At least people will pay something for drugs and something for vaccines. So we have a lot of work to do on the demand side for all three of these. Vaccines, we have public funds, we have Gavi. It's an easier case now compared to what it used to be. We don't have a Gavi for diagnostics. And we don't yet have a global fund for antibiotics, which I think we should.
Yeah, I've really been interested recently in the diagnostic thing, and it's the technology. We know we have tools, but there's a certain amount of social resistance to using them. I mean, it's an interesting challenge when it's cheaper just to take a pill than it is to take a moment to diagnose. And they're also taking a moment to diagnose. Sometimes it's not just a moment; it may take an hour or a couple of days, and that's a bit of an issue as well. That you don't. It's hard to know precisely how to weave them in, and yet. To extend one of my favorite metaphors, if antibiotics are the fire extinguishers of medicine, then diagnostics are the smoke detectors, and we wouldn't be in a building without good smoke detectors either. It's it's interesting to chew on that. Mm-hmm. Okay. Well, if you put all this together, you come to your paper number 4, where the goal here is to lay out some targets to be discussed and hopefully picked up at the UN General Assembly in 2024 in the high-level meeting. Why don't you walk us through what those targets and also a little bit about how you selected them?
Right. So I'll start the story slightly ahead in terms of what the overall messages are from these papers. We talked about burden, but what we didn't talk about is why this is important at UNGA. And one of the important figures that we have is figure 1 in the executive summary, which shows that both newborn mortality and under 5 mortality would have been on track to achieve the Sustainable Development Goals, but for AMR. AMR is really the main reason to stop this. And I think that we have to focus on our inability to reach other goals, including on healthy aging, where, again, elderly populations are very much at risk. But alongside this is the idea that we also need to reframe away from just AMR, as we said, is only a subset of the problem, which is of sustainable access to effective antibiotics. That is really the problem. AMR is only a symptom of that problem, one of the ways in which it shows up. But the problem is we don't have good access to effective antibiotics. And of course, when you have AMR, that makes that problem even sort of worse. So I think that is a general sort of language, which is, we've tried drug-resistant infections, all of them describe the problem, but I think the root cause is really the access. Then we come to the issue of the prevention, which we've already spoken about, and then we come to what we want from UNGA. And from UNGA, certainly a certain amount of political will has brought the issue to the UN General Assembly, but not sufficient to make progress after this meeting in the same way that I think we have seen insufficient progress on AMR since 2016. For 8 years, we have a few things to show, but huge gaps. 80% of national action plans are not funded. I think the number's even more than that. The drug development pipeline is better, but still, if companies are going bankrupt and there's no particular pathway for them to get out, that's not going, very well. But we do at least have CARB-X, AGARD-P, and the AMR Action Fund, all monies that came together after 2015, 2016. I think we have a continued problem in terms of the progress on the prevention side has not been tied in well enough to tackle AMR. We need to do a lot more there. We've done very little on access to existing antibiotics. I can think of virtually no program that we've done since 2016 at any scale to enable that. We have not, really made progress on diagnostics when it comes to deployment. So on every front that we think about, and I'm only referring to human medicine here, when we get into animal health, there's a whole set of problems there as well.
Right.
I think we've lost an opportunity. So we need to have, at this UNGA meeting, targets. We need to have funding to support those targets, and then we need accountability. And targets are very simple. It's a 10% reduction in human mortality from AMR against a 2019 baseline measured in 2030. So, there's still another 6 years in which to make progress. 20% reduction in inappropriate antibiotic use in humans, but against a backdrop of universal access to the access category antibiotics. And then the third is a 30% reduction in antibiotic consumption, which is inappropriate in animals, which the animal sector feels is quite doable. So those are the 10, 20, 30 by 2030 targets. And I think it represents progress across the One Health range, and is likely to make sure that we get someplace better than we are today, and we're measuring against that.
Yeah, and it's interesting to see how the pieces fit together. Yeah, you look at your target number one. This is stuff that was beginning to be laid out in the push by the WHO around 2012, 13, 14 for everybody to have a national action plan. And the U.S. National Action Plan got written, I think, it started off in 2014, and that was, I remember it was 2012, the WHO annual, the event commemorates the annual birthday of the WHO. The idea of national action plans was the core theme there. So you're right, but it's only up to 25%, but at least, that's which I guess is up from 2% or 1% before that. So it's not great, but there we go. And then you look at the bit about, the whole idea of even having the scale of the AWARE, access, watch, and reserve antibiotics, and the development of that, along with the various antibiotic pipeline reviews. That's all stuff that's new that got created in order to facilitate even having this conversation. And fascinating to see the pieces and how many different sources have to come together to provide, I would call it, the data for action, the reasons to actually pursue this area. Oh, fascinating. Well, when you think about kind of the next steps, it's May. We're looking forward to UNGA in September. What are the things that the community could be doing to work in this area? And the one that's obvious to me is it's possible to write to your political representative. I mean, in the U.S., there's a way to do that. In Europe, there's a way to do that. Are there other things that you would think of if, besides get busy and discover drugs, develop a diagnostic, or work on policy issues?
I think the people who are discovering drugs are probably doing the most useful work. And certainly people who are expanding existing interventions that we have. So I think they should keep focusing on what they're doing. I think certainly writing to a member of Congress is not a bad idea, just because they hear from other issues, and we take this issue to Capitol Hill, whenever we can, simply because if you don't show up, then someone else is showing up in any case, and people just assume that you don't have really a problem that's worthy of attention. So in democracies, if you don't speak up, then the assumption is that there is no problem. That's just how this thing works. So I would show up, I would write op-eds, I would make myself visible, post on LinkedIn, whatever it is. We're a very small community that tackles AMR. These are all folks who who are on your mailing list, John. And so we really have to work together to make anything happen because, we just can't afford to go in different directions. The second is, I think we're gaining some momentum, but a positive narrative on AMR is helpful. For too long, we've called ourselves a hidden epidemic. We've called ourselves a wicked problem, a difficult problem, multi-sectoral. We've used all sorts of words that frankly scare people. And I think this messaging that also comes out of the Lancet series is that AMR can be tackled. It can be prevented. We can deal with access, and then we can come up with new drugs. It's very doable. It's only difficult if you don't put in any effort into it, in which case anything is difficult. And I think that positive messaging is something which, if you think of malaria, people know what to do. You spray larvicide, you use bed nets for prevention, and then you have diagnostics and treatment. It's fairly simple. TB, HIV. I'm not saying it's simple in terms of execution, but it's simple in conceptual understanding. And I think if we got to conceptual understanding of AMR, I think people should just say just these three things, which is we can prevent with wash, vaccination, and IPC. We can treat with existing antibiotics, or we've got to come up with new antibiotics. And that's pretty much it. That is the entirety of the solution to AMR. Now, of course, we know that each of those, to unpack those, takes a lot of time and effort, but we don't need to communicate complexity, at least if we want anyone to help us with passing Pasteur or with providing funding assistance for access programs and LMICs. So I think that's second is a positive narrative. The third is please do carry forward the target message. I really believe that if we don't have targets which are clear at the younger, we will waste time and we will lose further time. So 10, 20, 30 by 2030, it's easy to remember. And as a community, if we can, those are the Lancet targets now. If we can ask for the Lancet targets and anything we communicate, then I think we can make progress.
Yeah, and actually, we give a shout out to one other paper that's in the collection. It's a commentary by the WHO AMR Survivors Network, and I have been delighted to see this group come together, and their message of AMR is invisible, but I am not. I think it's exciting to see finally a real voice for this community. We've struggled to achieve that previously. IDSA worked really hard to try to get that going a few years ago, and then material's still online. But it seems like now with the WHO behind this group, we're seeing a very powerful set of messages that actually come back to your theme of a positive message. Yes, it was awful, but I got treated, and there are things that we can be doing to move this along. So it's a very, very exciting time. Well, I will say, let me just say thank you for what you've done. It's you and your co-authors. It's obviously you have been working for quite a while to pull something together on this scale, a year at least, maybe longer, to generate these data.
So yeah, it's about a year and a half, perhaps, and it's been an incredible team, 40 co-authors, all of whom have contributed. They represent a range of LMICs and high-income countries, very globally distributed, and a lot of them who are writing in sort of this kind of space for the first time. They've all worked in AMR for a long time, but they haven't been part of these kind of broader Lancet-type papers in the past. And I hope that some of them, or at least many of them, will stay and continue to write in the space, at least on global policy on AMR and so forth. So it's been a tremendous experience for me. I've just really enjoyed it.
Well, and just though I know we'd wish for more. If you look back at the 2016 Lancet paper that you were behind, you're right, it's 8 years, and we have a lot of words. We don't have as much action as we would like, but at least we do have some momentum. And now, and I think increasingly the concept, the issues are understood by people outside of our little bubble. And I think that's, I also see that. I think that's very exciting.
Yep. And we've got to expand that. I mean, that's why bringing in the cancer folks in, bringing in the child survival folks in, the sepsis, the cystic fibrosis, this has to be tackled across patient groups. It can't just be just one.
Yeah, superb. Well, so let's pull this to a close. Thank you again for making time so quickly to chat about these papers. It seemed to me very important to get a good message out soon about what was in them. And I'm just, delighted to have them. I look forward to hearing the 10, 20, 30 targets articulated repeatedly at the high-level meeting at UNGA 2024. And also something you didn't mention, that you've called for the independent panel on evidence. And that's also something that the Global Leaders Group called for. And we heard last week that actually there's now funding for that. So I'm looking forward to seeing the independent panel come into play to continue to generate evidence for action, which is the thing that moves the needle.
Absolutely.
All right. Well, so Ramanan, thank you again. Safe travels, and we'll be in touch.
Thank you, John. Great to see you as always.
So there you have it. What fun to get to visit with Ramanan today, and sort of to say it again. Paper number 1, bacterial antimicrobial resistance is a threat to attainment of the UN's Sustainable Development Goals. Number 2, things we know how to do right now, wash, vaccines, better IPC, those things will partially bring it down and get us closer to our goals, but they alone are not enough. So paper number 3 says access. We need access to antibiotics, old and new, to diagnostics, and to vaccines. We're not using everything we have, and we also do need some new ones. And then paper number 4 presents this interesting idea of the 10, 20, 30 goals. 10% global reduction in AMR-related deaths, 20% reduction in inappropriate human antimicrobial use, and 30% global reduction in inappropriate animal antimicrobial use, along with the call for an independent panel on evidence. Great stuff. Exciting to see it. Take time to read the papers. Also a bunch of links below. Everything we talked about, there's going to be a link down below the video that you can look at. And thanks for listening. And as always, like, comment, and subscribe for more. We'll see you next time. Goodbye now.